This week in Pediatric Oncology, the podcast exploring hot topics and exciting advances in childhood cancer. TWiPO is produced by Solving Kids Cancer, nonprofits located in New York and London dedicated to improving research and supporting families, because every kid deserves to grow up. Subscribe to TWiPO through your favorite podcast platform.
This week in Pediatric Oncology, the podcast about new advances for childhood cancer. Hi, everybody. Welcome to episode number 108, recorded on January 12th, 2023. As you can see from my background, it's always spring in Columbus, Ohio. I'm Tim Cripe, your host from Nationwide Children's Hospital in Columbus, affiliated with The Ohio State University. And I don't have a co-host today because Dr. Weigel is traveling and unfortunately couldn't make it. So I'm flying solo, but I've got a number of really special guests today to round out our conversation. So I think it'll be a good time nonetheless. So our first guest that I'm going to introduce, who will then introduce our other guests, is I don't want to say old, a long-time TWiPO participant, having been on early episodes and helping me in the early days of formulating this podcast way back when. And that's Dr. Jim Geller from Cincinnati Children's Hospital Medical Center. Welcome, Jim.
Thanks, Dr. Cripe, and I'll presume we can be informal if that's okay. Call you Tim?
Yes, sir.
All right. Well, thank you for that. Yeah, no, it's wonderful to be on TWiPO again and to be a part of this process and to talk about liver tumors. I'm a pediatric oncologist in Cincinnati at Cincinnati Children's and involved with some of our local work, but also working with the Children's Oncology Group and some of the national trials. And, one of the privileges, as you know, Tim, of being a pediatric oncologist is working with phenomenal parents and children and just being a part of a team that includes them. And it's really a thrill to introduce Kelly and Jess Woolwine, parents of Charlotte Woolwine, who did have hepatoblastoma. And I've just had a wonderful experience, although it's sad for some, but wonderful experience getting to know this family. It's a wonderful family. And just want to introduce Kelly and Jess.
Hello.
Hello. Thanks for having us. Fantastic to be included.
Yeah, thank you so much for being here. I think we wanted to have the three of you on together because Dr. Geller is a world-renowned expert in what we would call embryonal tumors, kidney, liver cancers, and has been leading the effort nationally and internationally in investigating these kinds of rare cancers. Jim, just as a little further background about you, you're a medical director of the liver and renal tumor service there, and co-director of the retinoblastoma service, and the lead of the scientific committee for the liver tumor group at the International Society of Pediatric Oncology, SIOP, and a co-chair and a chair and a vice chair for lots of different clinical trials. So, long, robust career that you're in the middle of, but going strong with lots of different really cool clinical trials that you've led or are leading. So congratulations on all that progress. And that's, we wanted to make sure we could tap into your expertise here. So we'll get to that in a minute, but let's start with Kelly and Jessica. Could you just tell us a little bit about your story, your journey, the beginning? Maybe we don't want to prolong it too long, but just give us some of the highlights and how this diagnosis impacted her and you and your family.
Well, let's see, 2018 was when it all started for us. And Charlotte was 3.5 years old. She was an extremely healthy child. She had really never thrown up before. That was just bizarre how healthy she had been her whole life. And so she got what we thought was a stomach bug and couldn't quite just get over it. We took her to the pediatrician and they thought that she might have appendicitis. When we went in to do an ultrasound to look at her appendix, that's when they saw her liver. And we were here in Roanoke, Virginia when that happened. And no one at Roanoke Memorial Hospital, where we were, had ever treated hepatoblastoma. So, they knew pretty quickly that there was tumor burden there. But then we were admitted. So we got up that morning and went to the pediatrician's office. And by that night, we were told that Charlotte had stage 4 hepatoblastoma, which had spread to both of her lungs. And we on a personal side, I know for me, I immediately started thinking, okay, well, what do we do? What's the next step? My first question was, can we even fight this? Is that possible? And the doctors here said, yes, we're going to go with, there's a protocol and we're going to start that. And, but the odds that they gave us were extremely low. And I said, well, as long as there's a chance that we can even start to battle this, that's what we're going to do. But Kelly and I immediately, learning very quickly, we had never heard of it either, and they had never treated it. We started doing our research and really trying to figure out what this was and who knows anything about it, and what all is she going to have to go through on this journey, and who will need to be involved in that. And so for us, we pretty quickly realized that we were going to have to leave Roanoke. And then it became apparent that we were going to have to leave soon.
Can you back up just a bit to start off with stage 4? That sounds pretty jarring. How long had she had symptoms, or how long do we think this might have been going on?
Well, she had the nausea and the random vomiting for a couple weeks, really. But she had pain in her shoulder for about 2 months before she was diagnosed. And I found that to be strange because I took her to the doctor twice for that. And they said, well, I think she's just pulled a muscle or something. But she had just this, at times extreme nagging pain in her shoulder. And my father, who is a physician, said, well, because I was worried about it. I think just mother's intuition, I knew something wasn't right. I knew it wasn't just a pull muscle. Something was going on. And my dad told me, he said, well, I find this very unlikely, but if there was something in her abdomen that was pushing on her diaphragm, she could be having referred pain. And I said, well, what would that be? He's like, it could be a number of things. Of course, my dad, I think probably already as a physician was thinking in his head, like the worst things it could be, which he didn't reveal to me. But that's when we were like, well, maybe it is like appendicitis. And there's just some swelling and that's what this was from. So technically her shoulder pain was the first symptom, but no one caught that. No one at her pediatrician's office had ever even, they didn't know anything about hepatoblastoma. And so then it was the vomiting really that got us to the pediatrician's office. But again, she wasn't really sick, even though on the inside she was really, really sick. And so that's it is jarring about this disease, is that it can become so advanced with very little symptoms. 2
things I learned from that story is your father's a smart man. And the other thing is cancer can be, hidden and mimic other things. Yeah. Sorry, Kelly.
Yeah. Well, I was just going to say, the thing that's unique about pediatric cancer and a rare pediatric cancer to boot, that's not on your radar as parent. I'm an old guy. If I went in and you hit me with something, I don't know that I would be all that surprised. As a parent of a 3.5-year-old, that's a train coming down the tracks that you never saw coming. And so the overwhelmment of that, and then when you pile a rare disease on top of it, heck, that most of the people who are treating you have never seen. The unique part about it is your instinct is just to let them put their arms around you. And what you want to do as parents is just trust in the people that are standing in front of you, that have diagnosed and said, here's our battle plan. As Jess said, they painted a very grim picture for us because I think looking back on it, all they had access to was statistics. Look it up. What are the numbers? Wow, Charlotte's got this and this and this and this. That ain't good. And that was their body language to us. So it was very tough. You want to take it on faith that your care providers, are up here on a pedestal. They've diagnosed it. They know how to treat it. You just buckle up, say your prayers, and you trust the men and women who are right there in front of you. But what we learned very quickly, and what I would say to anybody listening, is for God's sakes, we plead with you, if you don't do anything else, unfortunately, you have to take on the burden of asking questions and pressing for answers. You have to go out there, and should you have to do that, would you like to go into any competent care system anywhere in the United States and think in this day and age, you got the best available? You'd love to think that, but you just can't take that for granted when it comes to pediatric cancer, and particularly a rare disease. We don't take anything for granted. You know, we don't trust any answer we get in our life anywhere. We're very blessed that way. We asked.
I knew Jim was going to laugh.
I know we've made his life very difficult because we don't let him get away with anything without a lot of litmus testing. But we asked a lot of questions and demanded answers just to learn and to make, like Jess said, she was the captain of this. Is this all we can do? Is this the best there is? Are you sure about that? She really pressed on that. And I tend to be her worker bee, and it made sense to me. This is not enough. And so doing homework, getting out there online, calling upon all my professional relationships, anyone that I thought could be on the peripheral of the world of cancer. And, as you guys pointed out, when you put in the word hepatoblastoma anywhere to anyone that's ever heard of it or on Google, Dr. James Geller, you're going to land there when you go down that rabbit hole. So we were very blessed to have the inclination first to ask a lot of questions and not take answers at face value. And then second, that this disease had someone at the forefront of treating it like Dr. Geller. But again, in the interest of broadcast, to anybody listening, the what's the takeaway? Ask questions, push, and go look, because anybody can administer chemo. But what we learned, what our oncologists told us, and this is an exact quote, and this is not against any of the men and women that are here doing their best. They said, you are going to get the same treatment protocol anywhere you go, and you're going to get the same chemo anywhere you go. So you might as well be here where your support system is. Well, what we learned at Cincinnati Children's is the chemo and the protocol that's published is a small tip of a pyramid that's much bigger.
Much bigger.
Just the tip of the iceberg. The things that Dr. Geller and his team and the men and women at Cincinnati Children's did, 80% of all the things they did on a daily basis that save Charlotte's life and keep us in the game were not on the radar where we were diagnosed.
And the only way that you could know how to navigate these little things and nuances that came up, even just very small details of her daily care, someone who is treated at least one, or, where we got to go, Cincinnati Children's, who've treated several children with this exact rare disease, they know from experience how to answer these questions, how to navigate these nuances, how to really give the best care, because they've been through it. So it makes total sense that, of course, a facility where they've seen this over and over would be more fine-tuned to give the best treatment. Treatment is not just words on a paper. It's so much more than that. And we know that firsthand because of our journey.
I wanted to unpack a little bit of what you said a little more in terms of asking questions and seeking advice and Googling and all that, because what we have found is our patients often will get a lot of bad advice, or everybody and their mother and Uncle Joey, or everybody wants to send you their thoughts. You got to take this herb, or you got to do that. How do you weed through the bad advice or did you get what you in retrospect think was maybe misguided advice from anybody, family members or others, friends? And how do you weed through that to what's sort of the real stuff?
Well, you're right. I mean, we got everything in our inboxes from, doctors and hospitals to, herbal supplements. Don't trust the doctors. You get everything. I think the key point of data for us that Jess talked about is whatever disease you've been diagnosed with, somebody out there, however rare it is, who's treated more of it than anybody else. And when we went digging at hepatoblastoma, we talked to a lot of doctors who were learning from Dr. Geller. And when you look at who's treated, how many of this, where did they go? It led us to him and his team. So my opinion would be if you're looking for anything credible, real, and data-driven, who's treated it the most? Who's seen it the most? Find that's the cheese in the maze. Go find it.
There are new resources now also that are available that weren't available when Charlotte was diagnosed. So this is a great point. I was going to bring this back up, and I'm glad that you did, Tim, because for a parent to figure out if they have the means to even leave where they are and try to find the best treatment, how do they do that? It's a great question. And, I will say I immediately, when she was diagnosed, also looked on social media and to see if there were any groups of families who were diagnosed. And that's a tricky thing to use as a resource because it's social media and you are going to have to filter through people's opinions. It's not very scientific, but I will say that the Facebook group for hepatoblastoma families that I'm a part of is sometimes very helpful. And everyone on there is pretty aware, especially the ones that have been on this journey for a long time. They know kind of the centers of excellence in the United States for hepatoblastoma, and they know who the people are that are really doing things. But now we have hepatoblastoma.org, which is a wonderful resource. And hepatoblastoma.org is set up very nicely to help families who were first diagnosed and tell them, here are the centers of excellence. Here are the places that are really doing something with hepatoblastoma. So that's a wonderful resource. Depending on what the cancer is, there are other resources like that out there for other rare pediatric cancers. Hepatoblastoma.org did not exist when we were diagnosed. However, it does exist now, and it's a wonderful resource. So there are those resources out there. And I think, if you can find a .org for what your child has, it's probably going to point you in the right direction. There's a couple other, I can't remember the name of it right now. There's another website that is supposed to kind of cover all pediatric cancers, and you type in your type and it tells you the best hospitals. I've actually gone in and put everything in knowing what I know now. I can't say that the hospitals that came up were even, I don't even know that Cincinnati Children's even came up, honestly, for hepatoblastoma. So I'm not really sure what their algorithm is. But yeah, I think that families, it is tough. It is tough to really figure out and get that information. But finding a .org and, worst case, social media, you go in these groups and, these families who've been at it for a long time, it's kind of a small community. You can ask a lot of questions and find a lot out.
Yeah, I think it's really important. We always say .org, .gov, .edu are reliable sources. Right. Everything else, give it a question mark.
Be careful.
It's really good advice. And good to hear there's resources because, we don't want to send everyone to Jim or he'll get overwhelmed. There are,
right.
Everyone
to Jim that we've encountered. So.
But yeah, so let's move on. We're going to run out of time pretty quickly here because it's good to hear from you and your perspective. Let's move forward in your journey a little bit. You decided to go and you met with Dr. Geller and Jim. I guess maybe what were some of your impressions about Charlotte or her situation or the family situation?
Yeah, Tim, thanks. And it was nice to hear you, Kelly and Jess, tell your story. I think some of the most important things that come out of this episode, Tim, are the parent perspective in pediatric oncology. So take whatever time you need for that. And I'm happy to talk about the liver tumor stuff whenever you need me to or want me to. When I met Charlotte, she'd been through a lot. Her parents had been through a lot. The treatment had was getting going. And she did have advanced disease and concerns for rupture, concerns for lung metastases, her age being greater than 3. Various what we call prognostic factors that we do look at when we risk stratify a child's situation and thinking about how intensive therapy needs to be given. With regards to delivery of therapy, just a couple comments. You're right, Tim. There are a lot of places that are equipped to do this. It's not just one. We do write trials collaboratively. Representations from probably more than a dozen centers were involved in drafting our national trial for hepatoblastoma that used as a benchmark to treat Charlotte. And it is true that not all centers have all the components of care that a child needs, such as liver transplant when necessary. And we try nationally to work together to bridge institutions that have the resources and have the know-how and those that know how to do part of it and have access to the rest of it and work collaboratively. And our hope is that every child, no matter where they're diagnosed, gets excellent care. and gets access and ideally gets care closer to home as much as possible. And again, there are a number of centers equipped to take care of the more complex situation. I thank you both for the kind comments. The optimism that I felt in taking care of Charlotte early on was largely related to the knowledge that therapy had shifted. There's some early data coming out of Europe in treating metastatic disease that was very encouraging. We had our own experiences of how to clear lung metastases with novel imaging agents and radio probes, fluorescent probes, and just a toolkit of being able to use more aggressive chemo, more aggressive surgery, liver transplant has expanded beyond what historical trials and data depended upon. And, when you see that, and as Tim, as you know, in our field of pediatric oncology, when you see the field shifting and you see the tools increasing and you see the outcomes starting to be impacted, it gives you a little bit it gives you a little more hope and a little bit more fight in the engine. And that's what we brought forward when we met Charlotte.
Oh, that's great. I'm sure they're feeling fortunate to capitalize on all the prior research that was going on and progress. And we always know there needs to be much more, and we'll get into that a bit. I'm sure our audience is going to want to know, though, how Charlotte's doing today. So Kelly and Jessica, tell us a little bit more about what's happening today. How is she doing?
Well, this has been a long journey. We got through the first part and got her into remission after that first year. And then we ended up doing relapse treatment in 2020 into 2021. And then we were clear after relapse treatment and have been for, it would be coming up on 2 years. But we actually this week have found something else we might have to go in and take care of in her lung. So we might be looking at one more surgery for her, unfortunately. But, we're hopeful. We're very hopeful that this is, the way I look at it is I'm able to kind of stand back and look at her journey from start to now. And it seems like we're getting to a place where, this may finally be it, and that's our hope. But yeah, we are going on our 5th year of battling this, and it's still not smooth sailing necessarily. Although she's been completely healthy and wonderful for the past 2 years, there just may be a little bit of work left to do. So
what kind of impact on her do you think there has been, and how did she handle and go through all this, and what has it changed in her life?
Well, Charlotte is completely magical is the only word that I can describe her, and that's not enough. She's incredible. She's the sweetest thing ever. But she's so incredibly brave and resilient and positive. She's so forward looking and positive, and she doesn't dwell on things, and she kind of just, in this beautiful way, moves through it, and she knows it's part of her story. She wears her scars like a badge of honor. And this is a little different ground. We're in new ground right now because she is 7.5 now, and we haven't had to have, in fact, to be honest with you, we haven't had the discussion with her yet about this new surgery that's about to happen. And so it's going to be a little different because she's a lot more aware now, and she's going to have different questions. And to be honest, that is a really new, difficult part of navigating this, is to keep it as hopeful and positive for her, so she's not scared, and so that she continues to have that brave, beautiful attitude towards all of this, because I think that's a big part of her healing and her getting through it. And so, yeah, that's kind of where we're at right now. We're about to have that conversation with her. So.
We're gratified to hear she had the last couple of years have been good. Sorry to hear there's a bump in the road, and our thoughts and prayers are going to be with her and you all for this and any challenges. One thing about pediatric cancer, I think it keeps you on edge for a long period of time. And lots of unknowns and fits and starts and things. Jim, what is the current treatment for hepatoblastoma? What do you have to put your patients through? And how well does it work? And what are the gaps left to figure out?
That's a great question, Tim. I first want to add a comment related to your question, related to what Jess just said, is that the current treatment it includes pressing the gas pedal when you need to press it, and having some perspective that a lot of these kids, even after they relapse, can be cured. The cure rate after relapse is not inconsequential, and multiple relapses are not uncommon in the lung. Late recurrences that are amenable to lung surgery. I get calls from oncologists around the world at times wondering what to do the second time, and keep at it is my message. Keep at it. A lot of these kids are cured. And clearly I'm on the record here, and I remain very hopeful for Charlotte. No one ever gives a guarantee in oncology. My hat's off to the strength of Kelly and Jess to join us today. But I just want to express true hope and optimism, and keeping at it is a message I would share with our oncologists, especially when they are slow, indolent processes, because these kids can do well. That's the back end. On the front end, we do stratified therapy to answer your question directly, Tim. There are patients who present with low risk who can be resected and do fine. It's a very rare group of what's called pure fetal hepatoblastoma. That's stage 1, where you resect it and you give no chemotherapy. The larger majority of patients who have resectable disease up front, about 20% of the kids, have what's called group A disease, and they generally require a couple cycles of chemotherapy with very, very high survivals. And it's cisplatin based. With a couple cycles, we usually don't see too many long-term effects, but hearing loss is one of the key ones. For those that have unresectable disease up front, but where there are no metastases, we do stratify based on other prognostic variables, such as where is the tumor in relation to the veins inside the liver, and how challenging would it be to be resected to rupture? Is it climbing into the vein itself? And this is something called a pretext score. And we are studying the best approach to that. There are lower risk groups where we're questioning whether 4 or 6 cycles of cisplatin monotherapy is enough. And then there are more advanced situations where we're testing the question of 6 cycles of cisplatin versus 6 cycles of cisplatin with other drugs like doxorubicin, 5-fluorouracil, and vincristine. And in the European side, they have an older approach that incorporates carboplatin as well for that group. And our current international study, called the FIT trial, incorporates a third arm in Europe. The fourth group are those that have metastatic disease like Charlotte, and it involves aggressive chemotherapy for about 11 weeks. And we hope that the lungs clear by then. For those that clear, they get another 9 weeks of chemotherapy. For those that don't clear, we're testing the question of adding a different agent, irinotecan, or adding an agent called etoposide, and seeing if 18 weeks of either of a cocktail afterwards makes a difference for those whose lungs don't clear right away. Of course, the primary tumor has to be dealt with, and in the more advanced situations, sometimes liver transplant is necessary. Overall, about 1 in 5 children diagnosed with hepatoblastoma seem to require a liver transplant. We are learning how to tailor all of these therapies. I threw a lot of drugs at you pretty fast and sort of glanced over. I know that we don't have an enormous amount of time. We're learning how to tailor therapy to the child better and better. Our efforts are to try and reduce therapy where we can, intensify therapy where we need to, try and reduce long-term effects and improve cure. And to do that, Tim, we're doing that through an international study I mentioned called AHEP 1531 in the Children's Oncology Group, or FIT, which is the international group. It includes Children's Oncology Group in North America, New Zealand, Australia. It includes the TWiPO, which is the International Society of Pediatric Oncology in Europe and Liver, which includes all the European countries as well as some others. It includes the Japanese Children's Cancer Group, which includes Japan and some other areas in Southeast Asia. It's a true world study. It involved 5 to 7 years of all of us from the world getting together to study this rare cancer. And eventually in 2018, it launched. And since then, despite it being a rare cancer, we're about to enroll our 1,000th child with hepatoblastoma through an international collaboration where we can really ask and answer some of these questions about how much does each kid need. So it is a rare cancer, and the only way to study it well is to collaborate. And I'm privileged to be able to be involved with that.
Wow, 1,000. That's going to yield a lot of information.
Our target's 1,200, but we're getting there.
That's fantastic. I mean, it's so, I don't think people on the call or listening probably appreciate the yeoman's effort it takes to be able to do international studies, especially with tissue samples being involved. So congratulations on all that progress. What are your big unanswered questions, do you think, for hepatoblastoma?
Yeah, Tim, I think it comes down to where can we get away with less and where do we need more? Reduction of toxicities is important. In my clinic, about half the children that get treated for hepatoblastoma usually end up with hearing aids for hearing loss as a long-term side effect. And understanding, can we give less cisplatin to some of these kids? Obviously, biology leading to better drugs is always nice, but with the current tool set, can we give less? And the other question is, can we prevent hearing loss with hearing protection agents such as sodium thiosulfate, which has recently been FDA approved for localized hepatoblastoma to try and reduce the rates of hearing loss. For those with more aggressive disease, some of the key questions are, when does a child really need liver transplant versus can a surgeon do some fancy work with their scalpel and do what's called an aggressive resection? And that's debated with children who have multifocal disease in the liver. Some surgeons can carve them out, and some surgeons, usually it's not a skill, it's an intellectual decision making. And the surgeons are working together nationally and internationally, actually, to try and ask and answer when an aggressive local surgery versus a transplant's the right thing. How to use a fluorescent probe into cyanine green and targeting lung metastases and helping resect these small nodules that if you give some of this into the vein the day before and you take a scope and glow some light on the lung, you can actually see some green glow in certain areas and you can pick up these micrometastases. And is that going to make a difference in relapse rates? Just picking up things that are less than 1 millimeter in size and resected impact outcome. How does that help at the relapse setting? That's an important question of how to use this new tool. And again, how much chemotherapy is needed for those who have metastatic disease. We are shifting the curve in outcomes there, thankfully. What remains the Wild West is how to deal with relapse. There have been no real formal studies, no long prospective studies. To achieve that, we've developed a relapsed and refractory hepatoblastoma registry that has launched. You can find information about that on hepatoblastoma.org, or if you just look up rrhbl.org. We're trying to centralize knowledge and collaboration with centers from around the country and investigators around the country. It's in collaboration under a liver tumor research collaborative between Cincinnati and Boston, but we're involving anyone interested to participate, not just at the parent level, but at the oncologist, surgeon, and biologist level. It truly is collaborative, discussed nationally, and how we can integrate people and advance our understanding of how to deal with relapse and second events. When you take rare and make it more rare, our knowledge base gets a little bit less and evidence becomes less, and we need to improve our evidence.
You think there's any role for immunotherapies, which are, a hot topic in cancer these days?
Yeah, it's a great question, Tim. There is preclinical work looking at PD-1, PD-L1, and various other genomic profiles and different findings within the cancer. And I think if you look hard enough, you can identify a predictive marker that would suggest immunotherapy will work in every cancer. Whether it will or won't is another question. Like other embryonal cancers, hepatoblastoma are fairly genomically inert, meaning they don't have lots of mutations. And we know that mutational burden or lots of mutations predicts for benefit from such immunotherapy. I've treated a few patients off not a clinical trial and haven't seen robust responses. There's anecdotes out there. So I say haven't seen robust responses. There's anecdotes out there. There's interest to try and study them more formally, the PD-1 inhibitors in particular. It is more complicated for those post-liver transplant that are on immune suppressive therapy, debated in the literature whether such patients should get immune therapy. And some do and some do okay, and some do and have liver problems. So it's yet to be formally tested. There's preclinical data that would point both ways, anecdotal data that may be on the slight side, but that's the best I can do at this point.
Yeah. I think, there's still much to learn and much to study, and it takes longer with a rare cancer like that. So Jessica and Kelly, we started this podcast where you actually gave quite a clear message to other parents in terms of sort of your thoughts and advice. Why don't we end the podcast on any message you might have for providers or advocates or government officials or funders, or what's your message for the professionals and the advocates about hepatoblastoma or pediatric cancer in general? What would you like to say to folks?
I don't think we have enough time to say everything I want to say. I will say first that other than, after Charlotte's diagnosis, the most heartbreaking thing that we encountered. So Jess and I were bound and determined from the start, to not let this, and this is full credit to her to set the tone with me that very first night, to not let this simply be a curse and bad luck. Like the demon had found us and we would never understand why. She set the tone that we should find the reason in terms of what are we supposed to do now and how we turn this into something other than just a tragedy. And so we set out to every bit of bandwidth we could spare here and there when we're not in treatment is, okay, how do we make the world better for the next kid and the next family? And so we've learned a lot about cancer culture. And other than Charlotte's diagnosis, speaking for me, the most heartbreaking thing that I have encountered is that the reality is so many of these things in treatment that Dr. Geller was talking about and even cure are just a matter of allocation of existing resource. And the harshest reality I've learned is that the reason there are not better treatment, not better access to data, and no closer to cure for some of these pediatric cancers is because there's no profit in it. It's not a revenue generator. There are things on the shelves at pharmaceuticals sitting there because it's not worth. There's no ROI. There's no profit in finishing this out and finding out if it's a benefit to children. There's not enough government funding because the numbers don't work. So there's only one thing that can fix that. Anybody listening, if you give a penny or a nickel to anything, if you're making your year-end contribution, money has got to find its way to pediatric cancer. And it's not going to be easy and it's not going to happen organically. So, help us overpower the lack of profit and bring resources to this. That's number one, because I can tell you, man, kids are curable. I mean, they fight and they don't even know they're fighting. Their bodies can do amazing things. Their spirit. I mean, little Charlotte's got the heart of a dragon. She, there was just all the things that Jim and his team did to her. She never batted an eye. And that's the wonderful thing about children. And then the other thing I would say is for the parents in general, you hear the word aggressive and sometimes in describing these cancers and diseases, and you'll hear Dr. Geller and his team talk about being aggressive in treatment. Well, the parents need to adopt that word too. You've got to stay energetic and hang tough. It is a marathon, not a sprint. One of the very first teams and doctors that I talked to as we were working down the rabbit hole to get to Dr. Geller, we were probably only 4 or 5 days into this journey. He said something that I'll never forget. He was saying, he was kind of shedding some light on what our journey was probably going to be like clinically and surgically and treatment, things like that. And my jaw was just hitting the floor because no one had said that to me yet. He said, you will not beat pediatric cancer. Number one, you've got to wrap your head around there's going to be a heavy price. Number two, you're going to be at this for a good long while. And number three, it's going to take everything and more. Get your energy right, charge up your batteries, ask questions, be energetic, be in the game, learn the labs, understand the language, talk to more than one doctor. And you know what's wonderful is the doctors, every doctor we encountered right up to Dr. Geller were approachable and informative and patient with us and answered all our questions. They were so accommodating. It's right there, but unfortunately in pediatric cancer, it's just not going to land in your lap. There's no resource you can just pull off the shelf, a directory you look at and it tells you where to go. So to the parents, be aggressive, get in the game.
That's fantastic, inspirational message and a call to action, and a good way for us to close out here, I think. So thank you, Kelly and Jessica, for being here and for all your great comments. And we appreciate your sharing your story with us today.
Thanks so much for having us, Tim. And as Dr. Geller said earlier, we're on record, and I would just not be able to live with myself if I didn't say the miracle we're living today are because of Dr. Geller and his team.
Yeah.
Had we not gone there, we probably wouldn't be here. And we are so thankful for the work that he and his team are doing. They are world-class, they are unique, and they are passionate about what they do.
Yeah, they are.
Well, thank you, Jim, for being all that and providing great care as well as research, and for sharing your knowledge and perspectives with us today. So I think that's it for this week. Thank you all for listening. Thanks to the team for Solving Kids Cancer, a nonprofit charity dedicated to improving survival through creating novel treatment options for children. Remember, the more we learn, communicate, share ideas, and work together, the faster we'll reach the day when all childhood cancer is preventable or curable. As always, keep up the fight, and thanks for listening to This Week in Pediatric Oncology.
We welcome your comments, questions, or thoughts on topics for future episodes. Just drop us a note at TWiPO@solvingkidscancer.org. You can follow Dr. Cripe on Twitter at KidsOncDoc. Send an email to Dr. Weigel at weige007@umn.edu, and find all TWiPO episodes at solvingkidscancer.org.